What's going on, guys? I wanted to run through our patient assessment skill sheet with you guys, and over the last several years I've discovered that maybe it's not as intuitive the first time you look at it, and I wanted to make a follow-up video to clarify our expectations and the flow of this patient assessment skill sheet. And so I'm going to screen share this. I'm going to put it up on the screen so you guys can all follow along, all right? Here we go. So the first thing you want to do after you've been dispatched to a scene is to size it up. That's what we call the scene size up, all right? So let's go down each one and kind of just check off the boxes. You want to ensure that you have your body substance isolation. There you go with that. Make sure that your scene is safe. When you arrive on scene, you're going to survey the land even before you step off the ambulance. So make sure the scene is safe. You want to identify what the mechanism of injury or the nature of illness, and sometimes it's both. And so this is a concept that's kind of difficult at the beginning of class because we don't really focus on trauma in the beginning, we focus on medical. And a common issue that I've noticed is our students would simply say, oh, that's the nature of illness. And that's not enough. We have to, based off of the patient's current presentation and the dispatch info we've received, what do you think the nature of illness is? Is it respiratory in nature? Is it cardiac in nature? Is it neurological? Is it immunology? Is it GI, GU, OB, GYN, right? What is the nature of illness? And as we move towards Unit 4, for trauma, that's what we call a mechanism of injury. It is the way someone received an injury or trauma. For example, a car accident, a fall, a GSW, blunt trauma, whatever it is. Next up, we want to identify the number of patients we have, and that may assist us in requesting additional resources, and that could come in the form of PD if PD isn't on scene. That can come in the form of ALS, and that's also kind of a concept that's difficult to understand at the beginning of class because we don't know the differences between ALS and BLS early on. And so throughout the class, Marty and I try to pinpoint the areas where ALS may be beneficial. All right, so make sure you want to request additional resources. That takes care of the scene size up. Now we're going to move on to what we call the primary assessment, which includes forming a general impression as well as the ABCs. So when we form a general impression, the main question I want you to ask yourself is the patient sick or not sick? All right, and that's kind of determined by their presentation. So first of all, are you able to get a description of the patient? So gender at birth as well as their age, what is their chief complaint, and sometimes or oftentimes that differs from what you were dispatched to. What is their level of responsiveness, if they're responsive at all, and if they are, how oriented are they? Are they ANO times 4 or anything less? Okay, and that's typically achieved by asking the who, what, when, and where, right? So who am I? Who is this person? Who is the president? What is going on? What brings us here today? Where are we? Are we at home? Are we in the ambulance? Are we at the park, at the gym, at the library? And what day is it? What day of the week? What's today's date? Be a little more forgiving with that. If I didn't have a job, I honestly wouldn't know what today was. And then based off the patient's presentation, are they in a certain position, like tripod position? Are they in fetal position? Are they crying? Are they anxious? What is their skin color and moisture look to you, right? This is all before we've laid a hand on them. Does the patient look sick or not sick, right? That's all general impression. Now, as we move on to the airway, if the patient is talking to you, you can safely assume, if you don't hear any abnormal airway sounds like stridor or grunting, that the patient's airway is open or patent, right? And if it wasn't, then how do we fix that, right? If you heard gurgling, provide suction. If you heard snoring respirations, maybe a head tilt chin lift or a modified jaw thrust, right? Move on to breathing, right? The first thing we ask in breathing is, what's the patient's tidal volume? Is it adequate or inadequate? And that helps us determine if this patient is short of breath, do we need to use a bag valve mask device, or can we fix this with a non-rebreather or a nasal cannula? All right, so what's the patient's tidal volume? What's the relative rate? We're not sitting here for 30 seconds counting a respiratory rate. We're looking at it for 5 seconds and determining, is it a slow rate, normal rate, or fast rate? What's the pattern, regular or irregular? All right, be very cautious, especially if there's any head trauma, because that may affect their respiratory pattern. Right? Any accessory muscle use or tractions, substernal, suprasternal, intercostal muscles being used to help expand that chest. What's the patient's pulse ox? Our students often fall into the trap of just looking and zoning in on that pulse ox and identifying whether or not that patient is short of breath. And I know it's difficult in the classroom setting when we don't have a sickly looking person in front of you, but do not fall into the trap of just looking at the pulse ox to identify whether or not someone is short of breath. Okay? What are their lung sounds? A lot can be learned based off their lung sounds, based off what kind of treatment they may need. If wheezes, then we might need albuterol and Atrovent. If pulmonary edema, maybe we can use CPAP, okay? So don't forget lung sounds. And if you've identified that the patient is in respiratory distress, have you treated this, right? There are certain treatments that we may administer, like oxygen and epinephrine, administer in the primary assessment because these are all considered life threats, okay? Whereas there are other medications where we need prerequisite information like allergies or prescription or a blood pressure prior to assisting or administering these. Let's move on to circulation. First thing you ask in circulation is there any active bleeding? After that, you're going to assess the skin color. There's 3 parameters to that: color, temperature, and moisture. All right? Normal parameters are pink, warm, and dry. Assess the pulse strength. So you're going to place your 2 fingers on the radial artery and you're going to assess the strength. Is it weak, strong, or bounding? What's the relative rate? Is it rapid? Is it normal? Or is it slow? What's the regularity? Is it irregular or regular? Is it equal? You're going to compare the right and the left side from each other. Are they equal to each other? What's the cap refill? Less than or over than, or slower or faster than 2 seconds? Okay. Based off of the patient's skin parameters and their mental status, to try to determine if they're in a state of shock. And this is very difficult in the beginning, but there are a lot of causes for shock, whether that's hypovolemia, burn shock, cardiogenic shock, obstructive shock. There are a lot of causes of shock, and I understand how difficult that can be able to determine that very early on, but that's something that you have to determine based off the skin. And some students really want that blood pressure, but the blood pressure is not taken in the primary assessment, okay? So if you've identified shock, then initiate shock treatment, which includes supine, like keep the patient supine, keep them warm, and then apply oxygen. The very last thing we do in circulation is identifying a patient priority for transportation. So this isn't to say that we won't transport. We never just give the option to the patient, do you want to go to the hospital? We always try to encourage the patient to go to the hospital. Now, if they're obviously A&O times 4 and they can make sound decisions for themselves, you know, that's another story. But what I'm trying to talk about here is, do we have to load and go, or can we stay and play? Do we have the luxury of obtaining more information on the scene, or do we have to be urgent and expeditious with our care and continue some of our care in the back of the ambulance on the way to the hospital? That's something that you have to ask yourself, and that's determined by the patient's presentation. Did you have to do anything in the airway, breathing, circulation? Did you have to stop a bleed? Did you apply any oxygen? Does anything look abnormal to you? That would help determine the transport decision at that point, all right? Now, the section that we're about to move to, the umbrella term for this section is called the secondary assessment, and that includes history taking like OPQRST, sample, vital signs, as well as the focused assessment. So we teach our students in the beginning, just follow the order of this, and towards the end of class, you have some freedom to kind of change the order of these things. So if we were to start with OPQRST, a lot of students confuse onset and time, the O and the T. So when we think of onset, I want you to think of, did this issue, whether it was pain or respiratory distress, did that come on suddenly or gradually? You don't ask it like, how long have you been complaining of this issue? Because that's time, right? That's duration. So onset is sudden or gradual. The P stands for two things, provocation and palliation. What makes it worse or what makes it better? What makes your respiratory distress worse? What provokes it? And what palliates it? What makes it better? Quality is, can you describe your issue in your own words, right? Be descriptive. And if they can't find the words, over time and experience, you too will have the words to assist them. Radiation is, does the issue go anywhere else? Typically with pain, all right? Severity, on a scale of 1 to 10, 10 being the worst, how bad can you rate this issue? And time, which is equivalent to duration. How long have you been complaining of this issue? Now, this highlighted green section, associated symptoms, relevant symptoms to consider for given complaint. This is where it becomes a little unintuitive for our students, but we give different skill sheets for the different units that we have. And so for this current unit, it's for respiratory and cardiac. So if we were to go down to this section, associated signs and symptoms, this is the section that we're thinking of right now. So we would plug and play these sections up into the general medical assessment. So we would ask our patient, do you have any of the following? Chest pain, weakness, fever, swollen hands or feet, or cough. And these are related to diagnoses and conditions that are related to respiratory illnesses. If someone was short of breath, they might have some of these associated signs and symptoms, okay? So that's what we mean by plug and play back into here, okay? That's what we mean by that. Now, if we were to move on to ample, the A is for allergies, and if you see in documentation NKA or NKDA, that stands for no known allergies or no known drug allergies, just FYI. M is for medications. Do they have a list of medications? And over time, just by looking at a list of medications, you'll be able to determine what types of issues or conditions this patient is currently experiencing. P for pertinent past medical history. Depending on their nature of illness, history tends to repeat itself, so it is crucial to obtain their past medical history because history, unfortunately, in this case, tends to repeat itself. The L is for last oral intake. What was the last thing you had to eat or drink? And that may be important for surgery purposes. That may be important for allergy purposes as well. The E stands for events leading up to current condition. And also important to identify what were they immediately doing prior to their chief complaint. All right. Now, next one is asks questions that are relevant to given scenario. All right, that's what we're on right now. So we're going to go back down to our focused secondary assessment and find that section and plug and play. So asks questions that are relevant to current scenario. So questions associated with complaint right here. Do you know to have or any symptom of a respiratory infection? Okay. Do you have a cough? If so, is it productive? What are you coughing up? Is it more comfortable to sit in a certain position? Do you have increased exacerbation at night? And we ask these questions more specifically for patients with congestive heart failure. That would be the current medical condition that we're kind of asking of. And after we finish that section, go back up. Okay, go back up. And now is a good time for the focused assessment. Okay. So now we're right here. Performs proper focused assessment. Okay, so we go back down and we're here. So we're going to look, listen, and feel. So when we look at the patient, we want to look for accessory muscle use. We want to look for tracheal tugging. We want to look for jugular vein distension, abnormal positioning like tripod position or sniffing position. We want to look for peripheral edema, so swollen hands or feet. We want to look for pursed lip breathing, which looks like this, which is generating auto PEEP, positive end expiratory pressure, which is a concept that we'll talk about in respiratory. We want to look for drooling and secondary skin conditions. Okay. Now, if we were to go back up, we are now at the vital signs section right here. So ask for a blood pressure, All right, ask for a heart rate, ask for ventilatory rate, go down to diagnostics. What's the blood sugar? What's the pulse ox by now if you've applied oxygen? And hopefully you want to identify a field impression. You're making an educated guess as to what you think is going on with the patient. Now, at this point, if you haven't administered a certain treatment that you might have already in the primary assessment, this is your opportunity to do so. So we're going to plug and play down back here, and we're going to look at any of these things. Did we apply oxygen on the patient? We have. We would have in the primary. If the patient had wheezes, we would have applied 2.5 milligrams of albuterol and 0.5 milligrams of Atrovent via nebulizer. And don't forget to assess the response to that treatment. Is the patient feeling better? How is their respiratory distress at this point? After the treatment, let's go on to reassessment. And you're going to demonstrate when to reassess the patient to determine changes in condition. So you're going to verbally out loud say, we're going to reassess this patient every 5 minutes if the patient was unstable, or 15 minutes if the patient was stable. So if you had to do anything to the patient, like provide oxygen and things like that, and even if they are feeling better, we are not definitive care. So we would still consider that patient to be unstable, all right? Repeat the primary assessment. How are their ABCs? Repeat relevant vital signs like their blood pressure, pulse, respiratory rate, and pulse ox. Check your interventions. Reassess the chief complaint and overall condition, and then provide an accurate verbal report. And an accurate verbal report, let's say if we were working on a patient who had respiratory distress, would sound something like this. Ring, 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 ring. Northwestern picks up. Hey, Northwestern, this is Chicago EMT training, Ambulance 1. We are BLS. How do you copy? They say loud and clear, Chicago EMT training, BLS 1. Go ahead. We are 10 minutes away with a 46-year-old male complaining of respiratory distress. Patient is currently ANO times 4 with a pulse ox of 95% on 15 liters per minute of non-rebreather mask. Patient was initially found in tripod position with clear lung sounds bilaterally, but their pulse ox was at 88%. They do have a medical history of emphysema and bronchitis, and we've applied 15 liters per minute of oxygen. No known allergies. We have a list of medications with us. Current blood pressure is 150/92, heart rate of 98, respiratory rate of 20, pulse ox is currently 95%, blood sugar is 88. Do you have any other orders? At which point they might tell you or ask to clarify something, and if not, they'll say, see you in 10 minutes, okay? I hope that helps, guys. Let me know if you have any questions. I want you to get the overall flow of the patient assessment from scene size up, primary assessment, make that general impression, do the ABCs, make a transport decision, and then do a secondary assessment, which includes history taking, OPQRST sample, as well as the pertinent focused secondary assessment. So whether that's respiratory, cardiac, immunology, abdominal pain, or neurology, plug and play. So I hope me going over this right now clarifies that. If you have any questions, leave them in the comments below. I'll see you in the next video.